pan-India ILD MDM. We have 6 diverse and challenging cases, and we have got our expert as Bhavin sir as a radiologist and pathologist expert as Ritu madam. We are expecting that Professor Athol Wells and Professor Sonia also will be joining in a short while, and we have 6
They have
cases.
both joined.
Yeah, we have 6 cases. 2 from me, 2 from Shobha madam, and 1 each from Rajan sir and Murli Mohan sir. So, and we have to finish on time. So let us start. I'll start sharing my screen. One second. So first case is from my side. I'll make it slide. So 1 second. Yeah. So she's 67 years old lady from Kottayam, and she has type 2 diabetes mellitus, hypertension, and hypothyroid. She presented to me with cough, with expectoration, dyspnea, and which is worsened over last 2 months. She was also having loss of weight for last 2 months of 6 kilogram. Exposure to biomass fuel, I don't know how much relevant it will be. Bilateral crepitation. Other than that, vitals were normal. Hallux valgus deformity was present in the left eye. There was a PFT done on 13th of May, which was 55% of expected. But when she came to me in October, her spirometry was showing FEV1 of 97, FPC of 97, FEV1 of 107, which was almost same in 23rd October also. Ratio of 116, DLC of 49, KC of 62. She walked for 300 meters. There was no significant desaturation. She was admitted that time we did, and they said there is mild pulmonary hypertension. And her ANA screening and ANA screening was 2+ positive here, which was fine speckled, and ANA profile positive, which was showing SCL 70 positive, amounting to 1+, and JO1 positive also amounting to 1+, which was myositis profile also again showed both JO1 positive, SRP positive, and NTQ positive. Unfortunately, Mithun is not there, but he told me that this looks like overlap syndrome, and I would like expert to say whether the profile matches with myositis or systemic sclerosis, but that is what our differentials were. And I will stop here and requesting Bhavin sir to show the images.
So, Asmita, the vital capacity was just over a liter, but 97% predicted or something. That was a little odd, right?
Okay. Can you see the images?
Yes, we can.
Yeah, okay. So starting from apex to the base, this is the axial study. You can see these reticular opacities. They are predominantly peripheral, maybe a little bit of an axial component in the mid zones. And then as we, am I there or am I gone? Okay. And then as we go to the lower lobes, you see this traction bronchiectasis. In fact, there's this area of subpleural sparing, and most of this is symmetric. There's temporal spatial homogeneity. And this is in fact, if you look at the sagittal images, we don't need to see the prone images. You can see this beautiful subpleural sparing. This is not commonly always seen, but when you do, we would say that this is a fibrotic NSIP pattern. There's no honeycombing, there's no significant ground glass, but there are these subtle areas of peribronchovascular opacities, or you could say ground glass with a little reticulation, which may suggest that there could be a mixed OP NSIP pattern. So again, this fits in very well with a connective tissue disease ILD, which even if we didn't have the serology, we would have said that that is a likely possibility here.
Yeah, can you hear me? You people are able to hear me, right?
Yes, yes, we are.
Okay. Yeah, because something happening between. Okay. And yeah, I did a bronchoscopy and lavage because we were planning to start her on immunosuppressant and ruling out tuberculosis. Unfortunately, there was a budding yeast cell with pseudohyphae, and Aspergillus niger grew in the culture. I have not started treatment for that. But we started her on MMF and Medrol 4 milligram, which she was already on. And yeah, sir was rightly saying that this is what her spirometry at our hospital was. Outside it was less, but our hospital it was like this only. And my doubt was like HRCT pattern is more in favor of like UIP because this was an overlap. So will will uh, will radiology help in differentiating whether it is myositis related ILD or systemic sclerosis related ILD? That was the doubt. And do should I start Perfenidone right away or should I wait? That was the doubt. Yeah.
The first question, which I guess is for me, is that most of the times you can't. Sometimes it is possible. So, yesterday there was this paper that came out of the National Jewish Hospital people where they talked of this pancake-like sign where you have only basal dominant disease in the last 2 centimeters of the lungs. Perhaps that is myositis, likely to be myositis, or if you have that rapidly progressive phenotype. And for scleroderma, if you have those low attenuation areas within the areas of XIP, perhaps you might say that that's more likely to be scleroderma. But most of the times, I don't think CT can predict which
Okay.
CTD it is. And if it could, then you wouldn't need rheumatologists, right? I mean, radiologists
Yep.
could then do everything. So it's
Yeah.
just that.
Yeah, I understand. Yes, sir. Yes, sir. Professor Wells, you wanted to say something?
Sorry, were you asking for me to comment on it?
No. Yeah.
It may be a bit of a fool's game trying to work this out, but I think it's valuable to try because if you can see a phenotype on CT that is typically myositis or typically scleroderma, it gives you a working conclusion on average. Now, the sound blurred a bit, and I haven't read about or heard about new signs. I would say, looking at the scan, we would probably, in our multidisciplinary meetings here, say that it was more typical of a scleroderma phenotype. And then the question is, you've got a vasculopathic profile. Whether you can trust an echo saying mild pulmonary hypertension where there's such little desaturation on a 6-minute walk test, I don't much care. But what you have got is a vasculopathic profile with the DLCO down below normal volumes, KCO 62, and I don't think there's enough ILD there. I know it can be a tough call, but I don't think there's enough to say this is PH because of severity. You can be fooled, can't you, Bav? And I tried to see you were going quickly, whether there was loss of volume in the lower lobe looking at the fissure against the diaphragm. I got a sense there was a bit, but you're not falling into that trap where there are tiny lower lobes. You think there's not extensive fibrosis, but you've actually wiped out the lower lobes. It did not seem to be that variant. So I think you're saying you've got multi-compartment disease where you can be reasonably confident of that. It all fits. And I think that would fit better with the scleroderma phenotype than an inflammatory myophenotype, although obviously you can get this in either of those two, but we're playing likelihoods. So I think I would manage this patient as for scleroderma NSIP in summary. Now, whether you really want to introduce an antifibrotic drug on day one, you think the DLCO might be driven more by vasculopathy. There's certainly significant ILD, but I guess I would have favored treating more traditionally for scleroderma lung with mycophenolate. However, we're here to debate, so I will shut up now.
Yeah. Madam, Sonia, madam.
So, I mean, I think that this is an interesting case because it raises the question of whether both of those autoantibody profiles are correct or one of them is incorrect. And, again, when I get into this situation, part of what I do is just really revisit how the patient looks and whether they have other features that are suggestive of either scleroderma or myositis or dermatomyositis. And You know,
She has features of systemic sclerosis, more in favor of systemic sclerosis than myositis. Yeah,
yeah.
clinical skin signs and all. Yeah.
Yeah. So then I think, I think that Athol is correct. I would treat this as if it were a systemic sclerosis. And I think that the only thing I would be a little bit cautious about is about the steroid introduction. And I know we had this conversation while I was there is,
Yeah.
we worry about scleroderma renal crisis. It's not something that you all have had a lot of experience with. So it's entirely possible that we kind of are looking at different populations. But I think that she's somebody who I would worry about a progressive disease. I think that I would keep a really close eye on her and get PFTs every 3 months. And her volumes are so low right now that she just doesn't have much room for decline. My major concern in adding a second agent right up front, that is like to add pirfenidone right up front, is that if she has intolerance of medication, I'd really rather her stay on mycophenolate than to be, trying to balance those two things. Um, but obviously, I mean, I think that this is what makes it the art. It's very hard to tell with any individual how they'll do with a medication.
I'm going to say something more because I want to vehemently agree with at least one thing that's been said. Steroids, I think, are a no-no in treating scleroderma ILD. Although I'm not a great fan of rigid guidelines, I think one of the pluses of the ACR ACCP guideline was to ban steroids in scleroderma lung, quite appropriately. What I would say is this patient got limited cutaneous or diffuse cutaneous scleroderma features, if you can answer me that.
I didn't examine the abdomen. I
The only,
saw facial features. Yeah, everything
sorry,
was. Yeah, her face was looking very classical of systemic sclerosis. I
main,
didn't see for other signs in the abdomen and other thing. Yeah.
I think there's a useful clue here from the trial of nintedanib, the census trial. What you see there is that you're losing just 90 mils a year of FVC in the placebo arm. But what you also see in that study, and it's quite well powered, and no doubt it's a biased population, you can't overinterpret it, but we've got to use what clues we can. That actually, if your FVC is above 70, if your FVC is above 70%, I seem to be talking to tech right now. But if your FVC is above 70%, you can scale down the loss of FVC. Now, to me, if you might be going to lose 60 mils a year of FVC, and the census study did suggest, at least in limited disease, that if you're on mycophenolate and nintedanib adds nothing, again, there are biases, but I think all of that adds up to not charging in with a second drug at the outset, and in somebody with scleroderma who may well have esophageal problems, promoting reflux doesn't feel like a good idea. So, Sonia, we're in this unusual situation of agreeing vehemently. I'm sure it won't last for the whole meeting, though.
Athol, I always agree with you. This is the thing I've been most amazed by over the years.
Okay, I think we'll move on to the next case, which is even more interesting, at least from my side. This is a lady from Maldives who came to see me last to last week, because we did a bronchoscopy also. She's 60 years old lady from Maldives, non-case of hypertension, diabetes, and 2023 she presented to cardiology department with progressive dyspnea, palpitations, and dry cough. Um, they did ECG and they found that it was a heart block and put pacemaker in 2023. CT coronary angiogram was done, which was showing normal coronaries, but they found there were multiple mediastinal and cervical lymph node biopsy proven sarcoidosis. So they went ahead and did PET CT. PET CT showed increased uptake in lymph node, lung, heart, liver, multi-system sarcoidosis. She went to Bangalore, consulted a rheumatologist, and she was started on medicines. So she was started. This is the drug profile. August 2023, she was initiated on systemic corticosteroids, which was continued in March 2024. Dr. Felt after repeating PET CT, there was no improvement. So she added MMF 2 gram per day. And then what happened is without any reason. There is because I asked the patient that why adalimumab was added. There was no reason, but in April 2025, methotrexate was added, and then methotrexate was switched to adalimumab. That is what happened. So MMF was changed to methotrexate, and methotrexate was changed to adalimumab in April 25. And now she came to me with complaint of fever, night sweats, weight loss, cough, dyspnea, MMRC 3 to 4 for last 1.5 months. And that happened because of that, the patient herself stopped adalimumab. And then in September, October, the treating doctor told her to increase prednisolone. She stopped everything. Methotrexate was stopped, MMF was stopped, and she was started on prednisolone 20 milligram per day. That is when she presented to me. Because of steroids, her fever subsided, and she suddenly started feeling better. But that was not the thing. So when I saw her, she was on 20 milligram of steroid. Otherwise, examinations vitals were normal. There was outside bronchoscopy in which NAT was done. It was not CB NAT, it was a NAT test PCR, which was negative for TB, and AFB smear was negative. Bronchoscopy and lavage was already done. This is the April 2025 PFT. We didn't do PFT because my suspicion was TB. And that time her FVC was 67%, FE1 was 71%, and FE1 by FVC was 87.5. DLC was not done, mild PR, no pulmonary hypertension. And other workup we did was negative. IGRA was done outside negative, Manto was negative outside. So we just want to show Bhavin sir to show the CT, whether CT would have picked up. Sir, you muted. Yeah.
All right. So we have the October 2023 scans, which I'm just quickly running through. There's nothing in the lungs, so we'll get that out of the way. There's a contrast CT which shows non-necrotic lymph nodes here, all in, around 15 millimeters to 10 millimeters short axis. It is consistent with sarcoid if, when we're considering that. But the patient also has pacemaker leads. I don't think that came up during the discussion, but
Yeah,
nevertheless.
pacemaker was inserted, sir. The diagnosis was with complete heart block.
All right. So then there must have been a cardiac component
Yeah.
at the time. Then there is a PET CT which was done, which is in
23.
March 24. And the PET also shows all of these lymph nodes. In fact, the PET shows that typical lambda pattern if I were to put it in the coronal plane, but we don't need to do that right now. There was no other evidence of uptake at that time, but you can see the lymph nodes here in the mediastinum. They're pretty much the same as they were in 2023. There's no significant change there. And the lung windows at that time in 24 also did not show anything significant, except you've got these little areas of subsegmental atelectasis in the lungs. But the current CT, which is the 27th September, is where we're now seeing these discrete nodules within the lungs. And these nodules, some of them have a perivascular distribution, some of them are fissural. They are not your classic 2 to 3 millimeter size disc. The one thing you'd worry about is TB in our country, but this is not that. These are classic sarcoid nodules that we're seeing within the lungs. And the lymph nodes, if you can see here, have regressed in size. So the patient is transitioning from what was earlier, I guess, a stage 2 to now what we would call a stage 3, where there's lung involvement and the nodes have regressed. So lungs were normal, now they're abnormal. Nodes were enlarged, and now they've improved. So that's where we are.
Left upper lobe, sir. There was something which looked like a cavity in formation or something. Yeah, that particular, or you feel that is also a nodule only?
It's just a clustered nodules, perivascular. That's it. There's
it.
nothing else.
Okay, I felt it was a cavity in form. Okay.
Arvin, are you going to show the signal in the heart? Have you got the images when there was signal in the heart?
So I'm going to look at the PET and see if they did a PET for the heart, but
I, I
I'm
think
not
it was,
sure if they did, preparation for the heart. But let me pull it up anyway and see if we can make anything out here. So that's the PET. There are these foci here in the lateral wall and here
yeah,
in the stem, which would suggest inflammation, assuming that the patient was prepared for a cardiac PET. Most of the times you could do a whole body PET where there's no preparation for the heart. But if there was, then this is involvement in the heart for sure. So this is the septal area where you can get complete heart block if this part is fibrotic. And then there's this lateral wall involvement here. So you're right, yes.
yeah, that would make sense. I mean, if you know there's sarcoid and you have complete heart block, at a certain age, you still have to exclude coronary artery disease. But with a CT coronary angiogram, I missed the age of the patient, but
60 years.
sorry?
60.
60.
Yeah, I mean, it's going to be overwhelmingly likelihood this is cardiac sarcoid. You see that signal. You'd like to know the SUV max, but in any case, you would treat to try to reverse the heart block. There's a reasonable yield for that.
SUV max is about 11 for the septal lesion, and in any case, it's significant. It's not.
Yes. Well, I think even if your signal was low grade, the heart block provides you with an indication. You're going to see appearing online a WASOG statement which declares war on steroids and sarcoid, and it's going to be out online in the next week, I believe. And this is an indication for short, sharp treatment to try to reverse heart block. At the age of 60, you would try to do that. Now, I think if you were older, you were worried about comorbidities, you might not. You might just protect, but you would protect with an intracardiac device, just a pacemaker. Anyway, that's not really the main thrust, except to say that the major indication for treatment appears to be cardiac sarcoidosis.
Yeah, so I actually was suspecting that I would do this thing again, bronchoscopy and lavage again, and we found out that MTB complex detected. Though it was low, we have got gene expert ultra over here, and that is we had very high suspicion of tuberculosis. So I also agree with sir that the CT scan findings were more in favor of sarcoidosis nodule, but the other thing which grew was MRSA. That is what came in the ball. Both the things were treated. She could not tolerate ATT within second day. I think first day of rifampicin, the second day her bilirubin shot up to 2.3, and I was worried. So I had to stop rifampicin. I never even given. I think I stopped rifampicin and pyrazinamide both, and now she's on this regimen. I made Visolon 10 milligram, and Mithun felt that methotrexate we will add only at the end of 2 months. So the questions were when it is safe to reintroduce methotrexate if we have got to treat both TB and sarcoidosis, and how much to step up steroids if we are suspecting overlap of infection of sarcoid, and is my time period of 2 months is appropriate, and that time patient will be only on steroids. She is not on any other immunomodulators. So those were the doubts.
But also wait for cultures, Asmita,
Yeah,
because
yeah, I'll do.
it's just a gene expert you have, and it was RIF sensitive, right?
Yeah, sensitive, RIF sensitive.
And if it's RIF sensitive, you got her on quite toxic drugs now because she can't tolerate rifampicin. She's got linezolid.
No, linezolid is only for covering MRSA. That will be stopped. No, no, no. I'm not going to give her linezolid. I
Okay,
will
I thought
stop
you
it.
gave it as an
No,
anti-tubercular.
no, 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 no. That was because the ball also showed this MRSA also, and I could not ignore that. That's it. Okay.
You've just got her on steroid and nothing else?
Yeah.
You're using bactericidal drugs for TB, right?
Mm.
So this is a setting in which people sometimes use heavy-duty steroid because they know that to avoid scarring, not in this type of TB, but just to say that you know that you can use best treatment for cardiac sarcoid, having introduced definitive TB therapy. You've clearly got two diagnoses. There's no way that the cardiac complex is about TB. One suspects maybe she developed TB while on immunosuppression in a TB endemic area. Maybe it's one of these rare TB mycobacterial antigens driving sarcoid, who can say? But I would manage the cardiac sarcoid as it should be managed. And I think if you failed to reverse heart block, you want to know the ejection fraction. But provided the ejection fraction is normal and all you've got is heart block and you have not managed to reverse that, then I would say for the heart, you can go for low-grade treatment. And sometimes we would observe such a patient. I do want to know the SUV max from that first PET, but I would not be driving cardiac sarcoid management upwards at this point. And what are you actually treating sarcoid for? You haven't really got the risk factors in the heart. There's no right ventricular involvement on PET. On echo, you would want to check the regional wall motion abnormalities. There's some stuff you could say on CMR if you did CMR. But basically, you've not got a high-risk patient, and there's a danger of too much immunosuppression and especially too much steroid. In the lungs, I think we'd say, Bhavin, probably that the nodules often will regress. They're the type of lesion that often actually resolve in time. The question would be if there's fibrosis there as well. I didn't see it very clearly. So I'd be arguing some restraint with immunosuppression, actually.
Okay.
You've
Sonia,
got
ma'am.
the ability to monitor the heart. You do need to check the ejection fraction.
I actually recently, when she came, her device was interrogated, her echo was done by our cardiologist, and her ejection fraction is fine. She doesn't have pulmonary hypertension. And I'm not sure about the heart block. I didn't check, but the device was interrogated recently when she came this visit when I admitted her. So cardiologist had a look and they didn't change any of the medicines as such.
We should not pour immunosuppression uncritically into cardiac sarcoidosis. You can align the risk factors quite nicely. The risk here is sudden death associated with heart block, but the rhythm disturbances don't tend to be driven by inflammation, but by fibrosis. And you've still got to go cautiously with immunosuppression, more harm than good sometimes. And there didn't seem to be enough signal other than trying to reverse heart block to pour high-dose therapy in this patient.
So this patient gave classical history that she was doing well on methotrexate. She was changed on to adalimumab, and as soon as it was started, within 2 months, she started having fever and all complaints came back. So
You think that was the release of TB, the anti-TNF therapy. Why was anti-TNF therapy used at all in the first place here?
I don't know. That was, we don't know answers. That's it.
Fortunately, the precedents around the world in cardiac sarcoid, people acting without advanced imaging, we're always treating people when the train had left the station with major problems. So cardiomyopathy, malignant rhythm disturbance. And we have this tradition, which is, I think is wrong.
So yes, you are right. Rheumatologist.
And you poison patients with far too much immunosuppression indiscriminately. The great thing about advanced imaging is we can save patients from their doctors sometimes.
So rheumatologist suggested that it is a trend that all cardiac sarcoid adalimumab has to be given, something like that.
No, just to add to what Athol's saying, as radiologists, we often save patients from all other physicians, by veering the report in a direction where they don't have to see anybody at all.
Okay, I think so. I'll continue, and no need to add methotrexate. That is what you're suggesting, right?
Well, look, I think if you're going to treat, you should use methotrexate and not steroids.
Okay, I'll add on after
But
once.
the liver has to settle.
The statement will urge minimizing steroids to 3 to 6 months as
Yeah,
bridging therapy.
sure.
The harm done by steroids is now a crisis.
Yeah, okay. I will add a methotrexate after 2 months, and we'll move on to the third case. I believe it is Rajan sir's case, right, Bhavin sir?
Yeah,
Okay.
So this is a patient who's I really wanted to pick the pulmonologist's brains on this because she's been following up for 20 years now. 77-year-old lady, homemaker, married with 4 children, never smoker. Presented to me in 2005 for 5 months with 5 months of exertional dyspnea, especially on slopes. Was desaturating from 95 to 84, TMT negative. ANA was 1 plus homogeneous. And on the scan then, which Bhavin reported 20 years ago, but that's still less than the time I've been working with Bhavin, fibrotic HP in 2005. And this is what we were treating this lady with, prednisolone, azathioprine then. Then I don't know why I gave her NAC then. I'm trying to think, but I think she didn't, her daughter, who's a paramedic, didn't want azathioprine on. So I said, okay, let's give something safer. And then in 2012, pirfenidone came on the, in 2010, pirfenidone was available in India. So we added pirfenidone because the fibrotic lesions had increased. And then we moved back to azathioprine because we just felt that azathioprine made more sense. The Panther data had come in then. And so we went to pred, aza, pirfenidone. And then she lost a little weight about 4 years ago, and so we switched pirfenidone to nintedanib. These are her bloods, and we recently, actually we never used to do myositis blots earlier. We recently got a myositis blot which turned out an OJ3+, and a pigeon serum. We also did an HP panel recently. The pigeon antigens were positive, everything else was negative. And so the next slide, and I'll just take you through her lung function so that you can have that context when you see the scans and then get my questions. That's where she came in with 20 years ago, 1.44, 52% predicted. Moved up a little with steroids, then moved her to azathioprine, and then was lost to follow-up, but stopped the azathioprine. And that's when I put her then on NAC, and you can see her vital capacity pretty stable, DLCO stable, desaturating to those high 80s all the time, normal echo. Next slide. And then we were on NAC. We added pirfenidone in 2012. Lung function marginally lower, but the vital capacity again remaining stable. That's where her DLCO is. 6-minute walks also, still not desaturating very badly, mildly elevated pulmonary artery pressure. And then as the pirfenidone went on, and you can see her lung function still a little on the lower side, DLCOs like this. PA pressure is okay. And this is the most recent trend in the last 5 years since COVID struck us, a little lower than 1 liter now most of the time. Again, the desaturation is the same. This is the first time we did a myositis blot, actually. Maybe I should have done it earlier. This was the blot. And then Bhavin will show the scans, and I really want a couple of questions answered. Yeah.
This is Sonia territory.
Okay, so I shall wait for Sonia to answer this one.
I wish Sujit would give me a little time. It would be nice to call them and get the 2005 scans. Because till 2021, we were calling this an HP pattern. So we were seeing reticular opacities, axial distribution, we'd actually used the term not even that. I'm just looking at the report from 17, and we'd said that this is in those days inconsistent with UIP. You have these axial, patterns here, and then there were these lobular areas of air trapping. Obviously, the ground glass, a little bit of traction bronchiectasis, predominantly fibrotic, but also a non-fibrotic component. And the only thing, and I think we should have at some point got that in, was that she was always progressing. So now, if you look at the 21 scan, the lesions have increased a little bit. And this is now the 25 scan here. And if you just look at all of them together, you can clearly see that there's progression. But when she came in April 25 this time, and now that, there's so much literature that we've been looking at about, sharp margins and sharply demarcated edges between normal and abnormal lungs, suggesting connective tissue disease. Look at this. I mean, this is as sharp as it gets. Now, while it's not a straight edge sign in terms of the coronal plane, it is a straight edge if you look at it from another dimension. And then when you look at the coronal images, you find that it is basal dominant, very sharp margins. Now this is a straight edge between abnormal and normal lung. And we actually revised the diagnosis. So I have the April report where I said, while for 20 years we've been calling this HP, perhaps we should revisit and consider the possibility of this being connective tissue disease. I mean, and this is so striking now. And I guess that's when I guess everything came together, and I think Sujit's also done the myositis markers, etc. So I still don't know where that is, but I'm just showing how the evolution has been. I mean, blindly we would have talked of this um, as a what we now call a BIP pattern. Now we would say this is a mixed NSIP-OP pattern. There's so much that's changed in 20 years and how we're labeling these. And today, if this case had come in, I think we would have really suggested that we should strongly look for connective tissue disease, given all of these findings. So, but it's progressing.
A BIP pattern with basilar
No. This is no
dominance.
longer, no. This is a NSIP-OP pattern, which is connected. And, sometimes with connective tissue disease, even if you don't use a pattern, this looks like CTD-ILD. The margins, whenever we see these sharp demarcated margins, I think more and more we're realizing that this points towards a CTD. I mean, look at this.
Sure.
You don't get this with other entities, this kind of sharp demarcation. We still don't know why that happens, but it seems to be happening.
So yeah, so I'm just wondering because I know Chris has got an article in press on the BIP pattern and the different types of BIP pattern, which hopefully hits the ERJ in some time. But this basilar predominance, he was telling me, would go in favor of CTD.
No, so yesterday, in
Yeah,
fact, this
yeah.
day before this paper came out of David Lynch's group, where they've used a sign called peridiaphragmatic inflammation and fibrosis. It's called PDIF. And I think the group earlier wanted to call it the pancake sign. And they say that if you have fibrosis only in the 2 centimeters next to the diaphragm and not anywhere else, and invariably this will be sharply marginated. Not only does it suggest CTD-ILD, it suggests myositis profiles.
Right.
So I actually went back and pulled out all the myositis cases of last year, looked at half of them to see if, and I found 2 of them with that sign. But then I found a Sjogren's with that sign as well.
Sure.
But it is a sign. It tells you that this patient doesn't have that because there it's only basal and nowhere else.
Sure.
It's a very interesting sign that they've talked about, but it's got published in an obscure journal. So I don't know why that.
No, so she's like 77 now. It's 20 years, Bhavin, since you've been scanning her and I've been seeing her. That's her. So the questions to Sonia and Prahlad, since Athol's taken a back seat on this one. Weight was 60 kilos, moved to 66, then dropped on pirfenidone, now again at 60. is this an myositis ILE with a fibrotic HP overlap? Currently, she's getting fatigued and needs a little nap in the evening. That's about it. She steps out of the house often, travels, tires after 10 to 15 minutes of walking. She's a bit irritable of late because of she gets tired. She's 92, 93% at rest. Now, what at 77 is my question, Sonia. Should we change immunomodulator? And rheumatology review is awaited. Unfortunately, our rheumatologist is not on the panel today.
So, I mean, I think that, we tend to think of patients as having only one disease, but I think that this patient potentially shows you that our patients have multiple diseases at once. There's no reason to think she didn't have an HP initially, and that she has over time evolved to develop another immune dysfunction. So, I mean, clearly, hypersensitivity pneumonitis is actually an immune dysfunction.
Right.
And so, I think that you probably have done her a lot of favor by having kept her on immunosuppression through most of that 20-year period of time. I think that in terms of deciding whether to add or change, what I always am thinking about is what is the downside of what I would do. So,
Yeah.
if she's somebody who has not had a lot of infections and is generally, pretty, responsible, then I think it is reasonable to talk with her about whether you want to add in rituximab. Not because I think it's going to make her a lot better. I think that she has relatively fibrotic disease, but because she has relatively low lung volumes at this point in time, you probably want to preserve as much as you can. Um, in if she were here, I might offer her IVIG, but I realize that that's more expensive there, and so I think rituximab might be the more reasonable option. Just recognizing that if she does get a viral infection, I would give her a dose of IVIG to try to limit any damage from that. But I think, what you just described is what we're starting to see as well, which is that when you follow people over decades, not just 5 years or a couple of years, we see these evolution of disease where, people have gone from having one very well characterized autoimmune disease to having something entirely different. So, I mean, I think this is a great teaching case. And you may never know, but I suspect you were probably correct when you diagnosed her with hypersensitivity pneumonitis, 20 years ago.
Thanks. That's very useful, Sonia. So you wouldn't change, sorry, there's some echo here. Yeah. Prahlad, any thought?
No, my side is no echo. What I would like to think that 20 years, okay, a patient is being followed so well and hardly any loss of lung function is there. Diffusion also fairly well maintained. Okay, and there is, yes, there is a shrunk, there is some loss of lung volume is there. And but what was the need for asking for a myositis when I would say that she is doing very well stable?
So, every time we tried multiple times to get her off steroids, but she'd get bad symptoms, and we'd keep her on 2.5 milligram prednisolone every day, try and get it to alternate days, but she'd get back on. And then finally, her daughter, who's, a lab assistant, said, can we just keep her on a small dose? She's on 5 mg, sometimes 2.5 mg every day. And then I think the myositis just came recently because, sometimes and I must say this is an error. Sometimes you take patients for granted and you just say, okay, they're doing okay. Let's not do anything. And that's the time we just decided, let's work up myositis as well. And then when it came positive, strongly positive, I was suddenly wondering, because her daughter also doesn't want to rock the boat. So when Sonia says rituximab, I'm just concerned at 77, I don't create a bigger problem for her. That's my only worry, actually.
I think not all myositis lung disease are very this OJ positive is it so aggressive? I don't think so. No?
I'm not sure. I've
No,
not.
it can be a progressive. And
It can be.
the problem is that you've been able to show radiographically that she has progressive disease.
Yeah.
Yeah. So do you think that
she's already proved the fact that this could be a progressive disease?
so this disease can remain so stable for 20 years? myositis with
So,
ILD.
so that's what Sonia was saying, Prahlad. Probably
Yeah.
started off as HP and then got
Yeah,
another
possibly.
yeah.
So if with the recent onset myositis, then do you think we should investigate her more to find out anything any
So
other reason for that?
rheumatology review is
Rheumatic.
awaited. She's due to meet a rheumatologist, and I'm wondering what more we can investigate her. But how much
What
to
about that
vote at
ground glass
77 is
appearance which
my
is there in the lung? Okay,
yeah.
that is also, you feel that is fibrosis or there's
It's
some,
fibrosis. It's not ground glass. It's just
it's
it
all
looks like
fibrosis.
that, but it's got traction bronchiectasis unchanged over so many years. It's not
Okay.
ground.
I think Professor Wells has raised hand. Maybe we can have his comment and move on to the last. Yeah.
Before I make two comments, I will just say it's an incredibly close call as to whether you use rituximab or not. And I think it's one of those things where you're talking to the patient and in partnership, you're deciding whether to risk issues at this age with infection. And you really want the patient, if possible, to take a view as to whether they would prefer to accept the risks associated with rituximab. I must say I'm slightly in Sonia's court, but I must say also it's an incredibly close call. 2 points I wanted to make. Firstly, from the history, I concluded one crucial thing. Bhavin is clearly older than 40 because he was reporting CT scans in 2005. This was something I had not realized.
You look younger than you, so I mean,
More importantly, perhaps, I buy completely into
Mm.
diseases. I see this an awful lot. And by coincidence, 2 weeks ago, a patient clearly had hypersensitivity 4 years ago, now has developed stonkingly positive myositis antibodies. And I think it's very interesting to think about why, and I'll keep this short. If you have HP, you will have epithelial disruption, you'll have immune upregulation, you're vulnerable to inhaled antigens of all kinds, triggering autoimmunity. We've got Mendelian data that quite a lot of rheumatoid lung is actually IPF causing rheumatoid and quite a lot of rheumatoid arthritis in patients with rheumatoid lung. So this business of fibrotic lung disease, disrupted epithelium, you've lost the barrier between the environment and the immune system. Then you add in the immune dysregulation of HP. I would say you're just primed to develop an autoimmune problem. And I'm only saying that because I've seen this a lot. And for clarity of thought, we say one thing in cause, but in life and in medicine, that is actually not the case.
Okay.
And Sonia, just one question. If it had to be rituximab or IVIG, would you give IVIG first and then the rituximab?
So, the reason we use IVIG rather than rituximab is just because it decreases the risk of the patient becoming infected.
Sure.
And so that's why the preference is for IVIG. But it also depends on whether the patient is willing to get an infusion once a month, and also whether they can tolerate the volume of immunoglobulin. So if Rituxan is available and more sort of easier for the patient to get, I would feel comfortable with offering Rituxan. And the only point I'm making is that if she does have a viral infection, I would give her a dose of IVIG because you can then try to help her control infection if that's what happens.
Sure.
Yeah. The fourth case is from Murli Mohan sir's side. I'm sure somebody's there from his side to present the case. So
Yes, ma'am.
please, yeah, go ahead.
Good evening, everyone. The case from our institute is a 47-year-old female from Bangalore who is an IT professional with nil comorbidities. She came to us for evaluation of incidentally detected lung parenchymal changes in CT-CAG, which was done for a mildly positive TMT in a routine health checkup. In the recent past, he had a history of fever, cough with expectoration. It was around 8 months back, followed which she had prolonged dry cough lasted for almost 6 months, which was treated initially with Budicort inhaler. Later, she stopped that and took homeopathy treatment for a few weeks. Then she got better. Since last 2 months, she is not having any dry cough or any other respiratory illnesses. On arrival, she was vitally stable. All the system examination was normal. Next slide, please. So there was no features suggestive of any connective tissue disorders, never smoker, no significant exposure history, no other significant respiratory illnesses in the past other than the recent history which I mentioned. And family history, her mother is asthmatic. She's a mother of six standard child with no abortions in the past. CT CAG has been shared with sir.
Okay, so all these cases I'm seeing today for the first time. So just give me a little. I just found something that was quite off, but all right. So we have limited images because these are the images reconstructed from the cardiac CT, and these are the cysts that they're talking about. Which morphologically, if you look at morphology as a sign, we're seeing something very interesting. So you see the cyst here, and we see this nodule within the cyst, which appears to be arising from the vessel, as if there's a small aneurysm in the vessel, and that's causing the cyst here. There are no paradiaphragmatic, ovoid cysts, none of those. In fact, this one as well is a classic aneurysm within a cyst. Wow.
Wow.
Okay,
Yeah.
so this is not PLCH, this is not LAM, this is not BHD, whatever the new names are. It is not Sjogren's, it's not amyloid. So you do get, if you look at nodules within cysts, then that's typically amyloid and light chain disease, or that's not this. These are aneurysms. So that's like, when do you get mid-arteriolar, pulmonary arteriolar aneurysm? You get that with what, Kawasaki and polyarthritis nodosa. Do you get cysts in pan? I don't know. I'll have to check all this. This needs workup. So the Dr. Lakshmi Priya, right?
Yes, sir.
You need to redo the whole study. You need to do a plain scan, an arterial phase, a venous phase, reconfirm whether these are arterial aneurysms, venous aneurysms. I was trying to look at the plain scan from the calcium score. They don't seem to be calcified, but we need to be 100% sure whether they're calcified or not. And only then we will know what to do with this. Unless somebody else has a brighter idea here, these are aneurysms within cysts, or rather the cyst may have occurred as a reaction around the aneurysm. I don't know. So
our MDT in NH, I'm Dr. Syed here, so in NH MDT, discussion was more towards amyloid. We were thinking can it be amyloid, but we don't have any other features.
Amyloid is, we've seen now a few, right? And I actually been foolhardy enough to biopsy a couple of them CT guided. So you don't get arterially enhancing nodules. You get nodules within cysts. Most of them are partly calcified. Your only problem that time is differentiating light chain from amyloid. It's really a one of those Aunt Minis. It's just a spot diagnosis. This is, if it turns out to be amyloid, great for the patient. But these are aneurysms. These are arterially enhancing, connected to the vessel lesions. And which means she needs a proper workup. We don't even know whether they're arterially enhancing, venous enhancing, whether there's some calcification prior to that, because there's no other scan like that. So first, before doing anything, just get a whole scan redone, right? Plain arterial, venous. I'm sorry, I'm repeating myself, but this is something else. We need to work this out.
Before the scan is done, Athol has some comments.
Yeah.
No, not a comment, but a question to Bhavin. So I'm aware of this as small print, but the disorder with both aneurysms and cysts is Behçet's. And so I have no idea what that looks like with cysts. I do know that cysts are described and aneurysms are described, and you're describing both.
Yeah, but Behçet's is proximal arterial. They present with large pulmonary arteries. I mean, unless there's a variant of Behçet's which can do this.
But
That's
well,
why it needs workout. I mean, I
I'm
don't
putting
think.
it forward because whatever this is unusual.
Yes, yeah.
And it's the only way I can unify the two words. That's all.
I
So
think just get this worked up, please. I mean, there's so much. This is a wonderfully interesting case from a radiology perspective and even otherwise, but it needs much more.
We'll do that, sir.
Will
We'll
do,
get
sir.
back to you. I think we have asked for other autoimmune profile, everything, no?
Yes, sir. Next slide I have included, sir. Autoimmune ANIF was negative. NIF was negative, and we have done whole exome sequencing also, thinking of BHD, though it was not a typical pattern, but it was reported no pathogenic or likely pathogenic variant, no FLCN mutation. Alpha 1 antitrypsin also within normal limit, it was 151. Serum Ig 61, NIF was nucleoli 1 plus, ANA profile was negative.
Yeah. I think the questions were answered, and we'll move on because
lung function wasn't done. Lakshmi?
Sorry, sir?
Lung function wasn't done?
Lung function, sir, IOS was done. It was completely normal, sir. The other spirometry DLCO will get it done in the follow-up visit, sir.
Okay.
yeah, thank you, Lakshmi, and we'll move on to the fifth case, Shobha Madam's case. Yeah, ma'am.
Yeah. Good afternoon. 67-year-old male from Kannur. He's working in Gulf in the pharmaceutical business. He has comorbidities of diabetes, hypertension, dyslipidemia, and significant coronary artery disease. He has a cough with occasional yellowish expectoration for the last 4 years, shortness of breath on exertion, which has not progressed beyond grade 2. He also noticed some itching in his hands, nighttime dryness of mouth, joint pain for the last 2 months, mainly the right hand MCP joints, middle and index fingers. He has a past history of dust allergy, no fever, no orthopnea, and he's not a smoker. And he had a CT chest done about 1 year back, which is not available for comments. Anyway, when I saw him, he had a saturation of 96, vitals were stable. Respiratory system examination showed bilateral basal crackles. I thought he had what appeared to be by mechanics hands. Radial part of the index finger showed thickening. So I think this was the X-ray which we took here. I think the CT scan is available.
Yeah, sorry. So I've just put up the axial coronal and sagittal images here, and we'll just start from the bases. We see reticular opacities with a little ground glass, classic subpleural sparing, more or less symmetric disease, bilateral. There is some traction bronchiectasis. So we're dealing with a fibrosing ILD. There is a fibrotic NSIP pattern, maybe a slight bit of an OP overlay, and very
Sorry to interrupt, sir. This is the other patient's CT.
Oh, okay. I have them as 5 and 6. So, okay. So this is the one we're looking at?
Yeah, this is the one.
Oh, this is the one. All right. Okay. Asmita.
I'm sorry.
That's okay. Please don't apologize. I'm just, we're all okay. So let me see. Reticular opacities, lower lobe predominance, traction bronchiectasis, no honeycombing, little bit of an axial distribution, but there is a lot of metry. Upper lobe much less involved. We don't have expiratory images, but I don't expect any significant air trapping here. I would actually start. Let me see if I can see the coronals as well. It is lower lobe predominant, but mainly axial, a little bit of this horizontal disease here. And then on the sagittal images, nothing much that it gives us. So this could be a mix. I mean, I would say this is indeterminate to start with. It is definitely non-UIP. I'm just a little not sure whether it's an OP-NSIP or whether there's also a BIP component, in which case we're looking at a mixed component, in which case, again, we start thinking of a connective tissue disease. So that's where we are. I think what's striking is the spatial and temporal homogeneity that the patient has. So that's where I am.
Okay.
Mixed pattern, but symmetry. So perhaps connective tissue disease ILD.
Okay. 1 second. I'll just share. I don't know what it is. Yeah.
Yeah. His lung function was reasonably okay. Mild restriction. DLCO was normal. 6-minute walk test. He did fantastic with the 6-minute walk test, 420 meters with no breathlessness. So reasonably good lung function. His CTD workup, the only thing which has come positive is PMSCL 100, which is this, and the myositis profile is showing PL7 positive 15. Yeah, so I would like to know what is the consensus diagnosis. Is it myositis ILD? And what should I do?
Just to ask you, there's no systemic features for CTD, I think I heard you say.
Yeah, there was no features except a suspicion of my mechanic's hand.
Said mechanic hands. Mechanic hands.
Oh.
Well, that's important, isn't it?
Yeah.
Because the serology is only just positive, and I'm not sure these trivial titers ever lead us very far. Any form of immune dysregulation, you're probably going to get a boost to your baseline titer levels. So if you're staggering to abnormality, only just crossing the line, I don't believe you can build anything on that serological signal, but the mechanics' hands are important.
Okay.
Yeah, so I mean, I think that the things that strike me about the case is that you described very nicely mechanics hands, and I don't know, has he seen a rheumatologist? The thing I'd be looking for is capillaroscopy.
They have not done that. Yeah.
Because I think if you get another soft sign of it being a CTD, I think that it would really add to your confidence.
Okay. Yeah.
But I do think that his imaging is a little concerning to me because it looks relatively fibrotic. He had lots and lots of traction bronchiectasis in there, given the relatively limited amount of reticular changes. So I would have a fairly low threshold to start him on immunosuppression. I would probably, either reach for mycophenolate or azathioprine in a situation like this. But I would keep a really close eye on his pulmonary function tests, which look great right now. And
Yeah.
part of the reason why I think that there's some equipoise here is because he's clearly somebody who's got some symptom burden, but he actually has relatively well-preserved lung function. What I'm a little worried about is that he's right on that edge of suddenly declining. So I would certainly talk to him, and he'd be somebody I'd be seeing, every 3 months just to make sure that his lung function is not dropping off. I agree with Athol. I think the problem is that the serologies are not super helpful. I think that they're kind of suggestive, but it's still a little unclear to me what his disease is. And, the other thing to think about is whether you want to repeat his serologies maybe in another 3 to 6 months and just see if he has a rising titer on one of these autoantibodies. But I would be, he's somebody I would have the conversation with and say, we can either do this one of two ways. We can watch you for another 3 to 6 months, see how you're doing. But if you have any worsening of your symptoms, any new symptoms that emerge, I would begin treating him. And again, I would have a rheumatologist look at him and particularly looking for capillaroscopy.
Okay.
Thank you.
Yeah, I think, we'll move on to the last case.
Just one quick comment on that case we've just discussed. I think around the world, a fair few multidisciplinary groups would have called this case unclassifiable. I think we've got to have the courage of the lack of conviction in cases like this, and we've just got to say that CTD-ILD is more likely than not. And I don't much care if you say it's a tentative working diagnosis or a more confident working diagnosis. You can't take refuge in unclassifiable in a case like this, I believe, because that leads to therapeutic paralysis. And I absolutely share your concerns, because I think the worry is that the CT suggests that if something gets worse, it may get worse on a very wide extent. And so the tide may be only 6 inches deep, but if it comes in, it will come in with a vengeance. And so I think treatment from the outset is essential.
Yeah. Moving on to the last case, and Madam.
Yeah, he's a 64-year-old office staff working in Gulf. He presented with 3 months of persistent cough with scanty mucoid expectoration, worse during talking, and he had a shortness of breath on exertion, again for 3 months, grade 1 to 2 MMRC. His symptoms occasionally caused disturbance of sleeping. He had lot of GERD related symptoms. On probing, he confessed that there is a history of discoloration of the face and arms, blackish areas on his face. He is not a smoker. He has a exposure to parrots for 2 months inside the flat. That was 2 years back. At that time, he did not have any symptoms. And there is quite a lot of exposure to pigeons outside the flat, in the kitchen windows, and so on. He had a clubbing, and the respiratory system showed bilateral basal crackles. And his lung function was reduced, FVC of 58, DLC of 39%, slow vital capacity again 57%. But he did very well with the 6-minute walk test, where he had no breathlessness and he walked for 20 meters. And echo was normal, there was no pH. And his lab workup showed 2+ positive, fine speckled, hemoglobin 11.3. ANA profile showed AMA M2, which I thought was not significant. And myositis profile was normal. Yeah, X-ray. Yeah, this was the X-ray. And CT scan, I think the first one Dr. Bhavin showed was this chap's.
I sometimes wonder when I, see these patients from y'all, whether you ever get local patients. I mean, all your patients are from the Gulf or Maldives or Mauritius or from these exotic places.
No, they are all local who are settled there.
Arey yaar, it's a joke. My God. Yeah. So this is the patient, right? So we'd already gone through this. It looks like an NSIP pattern. Maybe there's an OP overlay. You can see the coronal images here and the sagittal here. So that's it. I mean, there's nothing else here. And again, we would have said to consider connective tissue disease as an etiology.
Okay. Yeah.
The autoimmune workup was negative, right, Shobha?
Negative, except for AMA M2.
Yeah.
That was borderline positive, nothing else. Fine speckled ANA, 2+.
Sure.
Questions are this, and I think if Bhavin sir wants to leave, if there is no radiologist question, sir can leave. We have freed you before 6:15.
Yeah, I'm just going to try and see if I can share that paper that came out
And
yesterday.
there's only one scan, right, Shobha? You don't.
His symptoms is only for 3 months, and he landed up here. We did a CT scan, but he has got clubbing, and there is quite a lot of loss of lung function already.
Yeah.
Yeah.
What about the pigmentation, ma'am?
He has blackish whole
We don't
face.
have reason for that, right? Not
No
additions,
reason.
nothing like that.
No
Yeah,
reason.
okay.
It's all other liver function, everything is normal.
Okay.
Would these be also cases, Sonia, where a nail follicularoscopy would help to get a signal, you think? Or would you biopsy those patients if they had a positive NFC?
I would definitely look at the skin since that's one of the things that you've really pointed out. I mean, so one of the questions that I have is in people who have darker pigment, when we see a lot of the manifestations of myositis, they appear black rather than appearing red, which is how they look on lighter skinned people. And so one of the things I'd look at is just sort of his around the nail bed, whether he has black rings around his nail bed and whether he has ragged cuticles. Because men don't tend to have their nails done, it's ragged cuticles are more useful in men than they are in women, at least in the US. I can't say that that's true in India, but in the US, that's the case. And the other thing is whether the darkening, if it's completely surrounding the eyes, if it's on the chest, if it's around the back of the neck. The other thing that this is kind of making me a little worried about is whether it's a paraneoplastic syndrome with the amount of
Yeah.
pigmentation that you're identifying. And certainly, dermatomyositis can be a paraneoplastic syndrome. Um, the volumes were low compared to what I would guess for that, which makes me think that his diaphragm is elevated. And again, that image was a really nice image for that idea of pancaking of the lower lobes. So sometimes you can see that with early myositis where the diaphragm actually is weak and rises. And so the lower lobe looks like it's pancaked down, and the volumes are very low in comparison to what you would expect for the amount of interstitial disease. But so when you see paraneoplastic dermatomyositis, sometimes you'll see NXP2 or TIF1 gamma, but increasingly what we're seeing when we do these immunoprecipitations is that you have unidentified antibodies. And so they're probably a class of antibodies that are paraneoplastic that we don't actually test for yet. So I would certainly do like a full evaluation, age-appropriate evaluation. I'd probably do chest, abdomen, pelvis, make sure he's had a colonoscopy, a PSA, and anything else that fits with what his exposures are. You mentioned he works in the Gulf, and I'm sorry, I missed this worker. He
Yeah,
doesn't have
office worker.
exposure. Okay,
No.
so at least that you're not worried about him having some other exposure. But I don't have a really good sense of what that is, but it looks to me like the pattern fits with it being autoimmune, and the skin involvement makes me a little bit concerned, that this is either going to be in a myositis spectrum, a DM spectrum, or it's going to be a paraneoplastic syndrome. And I don't know if Athol has other thoughts about this.
I had to text somebody who texted me, so I missed the lung function and would like to see that.
Yeah.
And my only comment will relate to that because I think the suggestions you've made, Sonia, speak for me. Yeah, I had wondered about extrapulmonic restriction, hearing about bad lung function. This is absolutely not the profile of that. I mean, the DLCO is appropriately 20% below the FVC, so I was just dismissing that. It's curious the lung function is so bad, isn't it, for the extent of disease on scan? I don't suppose we can look at the scans again, can we?
I think Bhavin sir has left, but I will show you the selected
You
images.
can just take me to the top of the diaphragm on the right, just where the diaphragm on the CT, you get the top of the diaphragm.
No, I'm not sure.
So
Are
on the
you?
coronals, it looked like the base of the lung was pancaked.
Yes, so in other words, you might have very small lower lobes. And that will mean in turn that what you think on a global lung assessment is not extensive. If you're nearly wiping out the lower lobes, they've contracted right down. You get this false sense that disease is more limited than it is. All I wanted to see, but I think the comment was made on other grounds, but the fissure should be just at the front of the top of the diaphragm. And in a case like this, you'll often see it's pulled right back, and then you realize the lower lobes are tiny. So you've got hugely more ILD than you realize.
If the whole body imaging was negative, Sonia, would you proceed to a lung biopsy?
No, I wouldn't do a because I'm not sure it's going to help you. I think the imaging is very consistent with an NSIP pattern. So I don't think that actually identifying, I don't think that's going to tell you what the etiology of the disease is. I would do a skin biopsy if there's a place other than his face where you can biopsy it, because if it's dermatomyositis, you can often see, specific patterns in the biopsy. And that way you can kind of get another piece of information that pushes you in the direction of this being a dermatomyositis without an antibody that you recognize.
Probably PET CT scan probably help over
Yeah.
here.
Yeah, we can do.
That would
Probably
be
can,
another
especially you
reasonable
can
thing to
detect
do. Yeah.
myositis also.
Yeah.
If it's
Right.
there.
And of course, the area of the lung that's got the ILD is going to light up. But if you can pick up a lymph node or pick up
Yes.
PET avidity somewhere else, I think it would be very helpful.
I'll just say one thing about biopsy. It's one of those questions across a multidisciplinary group that if you've got 4 people in the room, you will get 7 opinions, basically. But in a case like this, but you're going to end up with a greater or a lesser suspicion of inflammatory myopathy when you've done the tests. And at the very least, I would say we think there's a lot more ILD than you realize on the scan based on the lung function. If we get to the stage we're not clear that this is CTD-ILD, I would manage with combination therapy, including an antifibrotic drug from the outset, personally, because I think the lung function is so bad that you probably need to empty your armamentarium at that point. You are looking at a DLCO of just 39%. And so if you're not sure of the diagnosis, I'd err on covering NSIP definitively with a worry this is unusually progressive. I realize we're supposed to use one treatment at a time, but I'm alarmed by the lung function. It's not explained by extrapulmonic restriction in isolation. The DLCO gives that away. So I would use combination therapy here.
Yeah, and I would not start 2 drugs at once. I think that again, it doesn't mean that I don't think that eventually you would need to add an antifibrotic. It's that, again, I always feel like if you start 2 drugs too close together, you end up with a patient who can't tolerate something and you can't figure out which drug it was.
No, I agree with that, Sonia. You have to, when you're starting to, you have to establish one at a time. The first one's tolerated, then you start the second one. What I'm really saying is I don't often start 2 drugs at the same time, but there is a point when you've got that severity of disease that you can look back afterwards and say that you made one of 2 mistakes. And the mistake I'd rather not make here is to fail to take an opportunity. And generally, I don't like starting 2 drugs at the same time unless you're straddling 2 diagnoses. You feel you have to cover both scenarios and disease is severe. I don't say I know that's right. It's a philosophical argument, isn't it?
Yeah. I think that's it. We finished 6 cases in almost 1.5 hours, less than 1.5 hours. So great. Come a long way.
Thanks
Yes.
for sharing some great cases. It's a good learning experience. Thank you.
Thank you for joining. And because Bhavin sir has to go somewhere at 6:15, so sorry if I was very fast and I was interrupting and going to the next case, but that was necessity because we needed radiologist till last case, and madam's 2 cases were remaining. That is why all cases were good, I believe.
We will need a review from every case.
As meter, I really want feedback of that case with aneurysms because
Yeah.
you do actually get aneurysms in smaller vessels with bedsheets. I think the drama is about the large vessels, but that is very well recognized. So I really want the feedback on that case.
We'll
Yes,
do
sir. We'll get back, sir.
Lakshmi and Syed will get back to us for
Right.
sure.
Thank you so much.
Thank you.
Thank you. And the next meeting will be on 14th of November, same time. Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Take care.
Bye.
Bye.
Thanks.
Take care.